Hi guys, my name is Taryn and I'm a nurse here at UK in the Trauma Intensive Care Unit. So today I'm going to be talking to you about traumatic brain injury secondary to a comminuted skull fracture and a subarachnoid hemorrhage. So the patient I'm presenting to you is a 52-year-old Caucasian male, initials of RM. He is single, he is unemployed, and the only family that we were able to get in contact with was a sister and mother that he is apparently estranged from. The only health history that this patient came in with was self-reported anxiety that he is not taking any medications for. And a lot of times in trauma, it's pretty normal to get a patient that comes in without any sort of health, any sort of medical or surgical history up until their traumatic accident. So the patient presented to us on February 2nd after being involved in a motor vehicle collision with positive loss of consciousness. The patient suffered from a traumatic brain injury secondary to a depressed skull fracture and a subarachnoid hemorrhage. We'll talk about the pathophysiology of that a little bit later, but first I want to give you a clear picture of this patient's stay from the time that EMS picked him up until he got to the ICU. So he was positive loss of consciousness at the scene, and then after EMS picked him up en route, his assessment was he had palpable pulses in all four extremities. The patient was hypotensive. He received 1 unit of packed red blood cells, and then he was intubated by EMS for a low Glasgow coma score of 5. He was a 131, meaning that he was not opening his eyes, he was not speaking, and the only motor response he had was abnormal flexion or decorticate posturing. And then the patient was also agitated, so he was intubated by EMS for those reasons. Upon arrival to the ED, the patient had bilateral breath sounds, peripheral pulses in all four extremities, and his airway was intact. His heart rate was 110 beats per minute. He was sitting 98% on mechanical ventilation. He was hypotensive with a non-invasive blood pressure of 75/60 with a MAP of 63, so you'll notice he also had a pretty narrow pulse pressure. And then he had a large scalpel avulsion with active hemorrhaging that was on the right side of his head, kind of from the top of his head all the way down to the back of his ear. So some diagnostic procedures that were performed in the ED upon patient arrival were a CT scan of the head, face, and neck, and a FAST exam, which is a focused assessment with sonography for trauma, which is performed to test for blood around the heart or the abdominal organs after trauma. So the CT and the FAST are both pretty routine diagnostic procedures that are performed on any kind of trauma patient that comes in. The patient's CT findings showed a 17 millimeter depressed skull fracture of the right parietal skull, which extends to the portion of the temporal bone, a right scalp hematoma, a hemorrhagic contusion, and a subarachnoid hemorrhage, fractures of the right zygomatic arch and nasal bones, large right-sided facial hematoma and perinasal swelling, and fluid, possibly blood, in the nasal cavity and paranasal sinuses. The patient's FAST exam was positive, and the patient was taken to OR emergently, which is routine. If a patient comes in and has a positive FAST exam, they emergently go to OR for an exploratory laparotomy, which is what happened in this case. The findings in OR were a small volume hemoperitoneum of 20 centimeters and a small liver laceration, which was controlled with cautery. Neurosurgery was consulted for the open right depressed skull fracture. Upon their initial assessment of the patient, their recommendations were that no acute neurosurgery intervention due to the patient was coagulopathic, so possible DIC, which is disseminated intravascular coagulation. They recommended antibiotic prophylaxis for the open skull fracture, so anytime you have an open skull fracture versus a closed skull fracture, your risk for infection is increased because your body's first line of defense is penetrated. And then Keppra for 7 days for seizure precaution. One manifestation of a TBI is seizures, so Keppra was given prophylactically. Head of bed to be elevated at all times greater than 30 degrees, and that's to prevent the increase of ICP, which is intracranial pressure. Q&A or neuro checks, so that any change in the patient's neuro status can be detected immediately, and to hold antiplatelets and anticoagulants for 4 weeks, and that's because the patient had a subarachnoid hemorrhage, so you didn't want to increase their risk for bleeding. So the next day, on February 3rd, neurosurgery decided that surgical intervention was now indicated due to the fact that the patient was in a motor vehicle accident and suffered a right open comminuted depressed skull fracture, which was causing significant brain compression. Upon presentation, the patient was noted to have some left-sided hemiparesis, primarily involving the left arm, likely related to his underlying brain injury from the depressed skull fracture. He was initially coagulopathic, which caused some concern for DIC, but after resuscitation with fluids and blood products, his labs improved and he became appropriate for neurosurgical intervention. The patient's pre-op diagnosis was a right open comminuted depressed skull fracture with brain compression and underlying brain injury. The surgical procedure performed by neurosurgery was a right-sided craniotomy, which is a surgical opening into the skull, for alleviation of the depressed skull fracture with duroplasty, which is when the dura is cut open and a patch is sewn to expand the dural surface, and then debridement of the brain. So on February 4th, which would be postoperative day number 1, the patient received a post-op head CT, which is routine, and demonstrated good decompression with expected cerebral contusion. The patient's Glasgow Coma score was a 361T, meaning he was opening his eyes to voice, he was following commands. He was a 1T at this point because he was still on mechanical ventilation, so he couldn't speak to us. The patient continued to display left-sided weakness in his left upper arm for the remainder of the hospital stay, and for the remainder of my contact with him. Broad-spectrum antibiotics were ordered for 1 week post-op. Neurochecks were to be performed every hour. Head of bed could not go below 30 degrees, and sodium level was to be maintained greater than 140. This patient actually had a problem with hypernatremia. His sodium levels were in the 150s, 160s. So he was on free water continuously at 30 milliliters an hour through his, at this point, Dopphoff tube. Neurosurgery signed off on this patient on postoperative day number 2. In their opinion, no further neurosurgical intervention was required for his TBI. And then on February 9th, the patient received a tracheostomy and a PEG for prolonged mechanical ventilation and feeding. A lot of times in patients that are failure to wean, or in this case, in a brain injury, who's going to be expected to have long-term mechanical interventions, they'll go ahead and trach them so that they could do trach collar trials, and then if they fail and can't breathe on their own, they can just pop them right back on the vent. Versus with an ET tube, you have to extubate them and intubate them, and you can only do that so many times. So they went ahead and gave this patient a trach. And then as of February 21st, which was my last encounter with the patient, he had been moved out of the ICU to one of our step-down units, and he was currently awaiting placement for TBI at a rehabilitation facility. So according to our textbook, Pathophysiology, A Practical Approach by Ms. Story, a traumatic brain injury is usually caused by a sudden and violent blow or jolt to the head, or a penetrating head wound that disrupts the normal brain function. Many TBIs will result in a wide range of long-term, potentially life-altering complications such as changes in thinking, sensation, language, or emotions. These injuries can increase the risk for seizures, migraine headaches, Alzheimer's disease, and Parkinson's disease. Open traumatic brain injuries can result in serious issues. In addition to the tissue damage from the impact of the brain with a skull, such injuries can cause damage from the penetrating object and skull fragments. Much like when an egg is broken, the skull usually ends up in multiple pieces when encountering an external force. The patient suffered a comminuted skull fracture, which means several fracture lines, and a depressed skull fracture, meaning displacement of the bone fragments into the brain. Open TBIs carry a higher risk for developing infections because of a break in the body's first-line defense, which we talked about, which is why the patient was on broad-spectrum antibiotics for a week after injury. Clinical manifestations of traumatic brain injuries may be vague and develop slowly, or they may be sudden and severe. Symptoms may improve and then suddenly worsen. The outward appearance of the head is not an indication of the injury's severity, and serious injuries can occur even while the skin and skull remain intact. Manifestations of a traumatic brain injury displayed by this patient were asymmetrical facial features and a fracture in the skull or face, bruising of the face, swelling at the site of injury, or scalp wound. So if you remember, he had that scalp avulsion that was hemorrhaging, and then the patient's right side of the face was swollen. You could just see it with each assessment swelling a little more. And then his right side of his face was just ecchymotic, black eye. He was just very bruised. And then fluid draining from the nose, mouth, or ears. So if you remember on the patient's CT scan, it showed fluid, possibly blood, in the nasal and paranasal cavities. Inability to move one or more limbs. The patient was displaying hemiparesis in the left side, primarily in the left upper extremity. He couldn't move. Loss of consciousness. He had a positive loss of consciousness at the scene. Hypotension. The patient was hypotensive en route and upon arrival with a blood pressure of 75/60. And restlessness. So even after the patient had his craniotomy, he just continued to be very, very restless in his bed. Just constantly kicking and rolling and trying to pick at things. Some other manifestations of a TBI are indications for concussion, such as amnesia, changes in or unequal size of pupils, seizures, which, remember, the patient was prescribed Keppra for 7 days for seizure prophylaxis, impaired hearing, smell, taste, speech, or vision, irritability, personality changes or unusual behavior, slowed breathing, lack of coordination, lethargy, stiff neck, and vomiting. So some of these signs and symptoms very well could have been present in this patient, but we were just unable to assess for that due to the patient's condition. He was on sedation for some time. He was on mechanical ventilation, so he couldn't speak to us. So some of these things may have been present. We just could not assess for them. Diagnostic procedures for TBI consist of history and physical examination, such as the Glasgow Coma Scale, a head CT, head MRI, and ICP monitoring. Treatment strategies vary depending on the severity and the time since injury. Immediate emergency care for TBI focuses on limiting brain damage and severe injuries, such as in this case usually require hospitalization, and patients with such damage often need intensive care. And this patient remained in the ICU for a couple of weeks. Osmotic diuretics, such as mannitol, may be given to reduce cerebral edema. Additionally, anti-seizure agents and sedatives may be needed. And surgery can be performed to remove blood or repair fractures. So, according to UCLA's neurosurgery department, treatment for traumatic brain injury, their criteria for surgical repair of a depressed skull fracture includes a depression greater than 8 to 10 millimeters, and if you remember, our patient had 17 millimeters, or greater than the thickness of the skull. Brain function difficulties related to pressure or injury of the underlying brain, cerebrospinal fluid leakage, and an open depressed skull fracture or fracture exposed by a cut in the scalp, which this patient had. So physical, speech, and occupational therapy may be required after the acute injury phase to minimize residual neurological dysfunction. And like I said, as of the 21st, my last encounter with this patient, he had been moved out of the ICU and was currently just awaiting placement in a TBI rehabilitation facility. So, working in trauma, every patient that I take care of is different, and no two injuries are alike. Although I've cared for many TBI patients, this was honestly my first pre- and post-craniotomy patient that I've cared for. I take care of a lot of patients that suffer a TBI and they don't recover. They herniate, family withdrawals, they go CODA, and they end up passing away. So, seeing this patient who first came in, he was posturing, he couldn't follow commands, he was hypotensive, his head was swelling, to, fast forward a few weeks down the road, and he was able to be weaned off the mechanical ventilation. He was following commands, he was opening his eyes spontaneously. He got moved out of the ICU, and he was waiting placement to be discharged for rehabilitation. So it kind of renewed my optimism. I'll carry this with me to remind me that every little thing that we are doing here is important and can make a difference in someone living or dying. I've seen patients like this go both ways, so to actually take care of this patient from start to finish and see him get better over the weeks, it really made me hopeful for him, and I'm excited to see how his recovery goes.